Hello and welcome to another episode of the Ultrasound MinnieCast, brought to you by AntMinnie.com. I'm your host, Amerigo Allegretto, and today we're going to explore the fascinating world of focused ultrasound treatments. My guest is Dr. Pejman Ghanouni. He's a diagnostic radiologist with Stanford Health Care Radiology, as well as an associate professor and chief of the Division of Body MRI at the Stanford University School of Medicine. He also serves as director of the Stanford Health Care Minimally Invasive MR Interventional Center and the Focus Ultrasound Center of Excellence. We're going to talk about MR-guided focus ultrasound and high-intensity focus ultrasound, including how they treat various pathologies like essential tremor, Parkinson's disease, prostate cancer, bone tumors, the list goes on. Dr. Ghanouni also tells some success stories from patients he has treated and why focus ultrasound is becoming a more attractive treatment option. It should be an exciting episode, and we thank you, the audience, for your continued support. Enjoy the show. So, how long have you been studying MR-guided focus ultrasound?
It's about 15 years now. Started as a fellow in radiology here at Stanford, exploring the interventional use of MR-guided focus ultrasound, first in preclinical models. We were working on experiments to try to trigger the ultrasound beam with the respiratory cycle as a way to deliver the energy in a more precise way. And then also in clinical applications, we started clinical trials. We joined national and international clinical trials that were ongoing. One was for treatment of bone metastases. Others were for treatment of uterine fibroids. And those led to FDA approval. We went from there to being involved in clinical trials for treatment of essential tremor, for treatment of Parkinson disease, bilateral essential tremor, prostate cancer. So it's been a kind of an ongoing process, but it all started about 15 years ago here during my fellowship, and then transitioned over as I joined the faculty.
And what drew you to this emerging area?
Well, personally, I had a hard time deciding between diagnostic radiology and interventional radiology. I wanted something where I could really do both. MR imaging was and is very exciting. I like the ability that MR gives to see pathology clearly and to have some insight as to the underlying cause of whatever it is that we're seeing, and depending on the organ. And then this interventional tool had a lot of potential, I thought. At the time, it was being utilized for uterine fibroids, although not in common use. And we saw it being used, or we first used it in patients with painful bone metastases as part of a clinical trial. And I remember just the impact of, kind of seeing is believing, where our first patient was somebody who, when we first saw him for evaluation for the trial, he couldn't sit down on the chair because he had a painful pelvic metastasis. And a week after, when we saw him in follow-up after the treatment, he was sitting normally. He had no pain when we examined him. And we realized we were onto something. This was really capable of positively impacting people's lives. So I guess in a broad sense, it was the merger of my interest in the technologies, both MR and focused ultrasound, with the ability to merge my interest in diagnostic radiology from focused on MRI, and then to bring to bear those tools to impact patient care in a very precise manner.
And could you briefly explain how MR-guided focus ultrasound works?
Sure. So if we take the focused ultrasound component of it, with diagnostic ultrasound, if we start there, the energy from the ultrasound device diverges, it spreads out, and it bounces off of whatever's underneath the transducer there. So let's say we're trying to image a vein in a leg, or a woman who's pregnant. We want to take an image of the fetus. The energy spreads out, it bounces off of whatever it's being aimed at, and the echo comes back and forms an image on the screen. Because the energy is spreading out, there's no heating. Focus ultrasound, imagine that you're taking a magnifying lens and focusing sunlight onto a leaf. You can take something that at most warms everything, but by concentrating it to a very small spot, you can set the leaf on fire. Same concept here. If we take that ultrasound energy that we were talking about before and concentrate it to a very small spot, the size of a grain of rice, for example, that focus gets very hot very fast, and the tissue at that focus is ablated, is destroyed through thermal energy deposition, through thermal changes. Mm-hmm. There are other mechanisms of action. It's not all thermal. You can, depending on how the ultrasound is designed and pulsed, you can get cavitation, which is a mechanical way using bubble generation to impact tissue function, by ablation, for example, that way. You can use focused ultrasound combined with microbubbles to enhance drug delivery by opening up blood vessels in the brain, for example, or elsewhere in the body. So there's multiple different mechanisms of action. You can use it for neuromodulation. You can use the ultrasound beam as a way to temporarily affect nerve function. So there's a lot of physics behind it, obviously, but the initial essence of it was being used for thermal ablation. You're using ultrasound for heating. You can use this focused ultrasound in combination with ultrasound guidance, which has been used for a while, but it's quite elegant when married with MRI. MR has the advantage of being able to delineate whatever the target is that you're aiming at, a tumor, let's say, and it could be a uterine fibroid, it could be a prostate cancer, for example, it could be a target within the brain. And you can see those targets really clearly. You can distinguish them often from the surrounding anatomy. And so you can use that as a way to know exactly where you want to position the focus of your beam. And also, it turns out that with MR, you can measure temperature. And so you can, with a sequence called MR thermometry, you can very accurately measure temperature during the energy delivery. So you can make sure that the tissue you're trying to heat up or ablate heats up long enough to be destroyed. If it doesn't reach a target temperature, you can increase the energy and try again. You can change parameters and try again. If you see that it's heating adequately, you can stop the heating when it reaches a certain threshold. You can look for any off-target effects as well. So that adds an element of both efficacy, because you're measuring the adequacy of what you're doing, and also safety, because you can monitor the tissues around where you're aiming and make sure you're not damaging that tissue.
And that kind of leads to my next question here, which is what advantages do you believe approaches like this or even high-intensity focused ultrasound have over conventional treatments for neuropathologies or body tumors?
Again, the main concept is the ability with these approaches with focused ultrasound, again, whether ultrasound guided or MR guided, the idea is to really target the disease, but minimize the side effects. And so what the imaging gives you is an ability to really tailor the treatment to the target itself while sparing the surrounding normal tissues. And of course, the more normal tissue we leave alone, we leave undamaged, the faster the recovery is, the fewer the side effects. And of course, this is an incisionless technology as well. So we can deliver this energy through the intact skull into the brain, or through skin into deeper tissues within the body. And so we avoid that whole wound healing process that's necessary after a surgical intervention, for example. I think that in this age, as you said, of precision medicine, to use your term, the elegance of this is the ability to tailor the treatment to the patient. In the brain, when you're treating tremor, or in the prostate when treating cancer, for example, patients have different risk profiles and they have different goals. One patient with tremor in their hand may want to simply be able to dress themselves again, close buttons or shave or put on makeup. Others may want to play a musical instrument or paint, something that requires more dexterity. So there's a range of goals that patients have. Some patients want you to get to 100% tremor relief, even if that introduces a small risk of side effects. Others would be satisfied with some improvement and try to avoid any side effects. So there's a broad range there. That's the patient component. Of course, the imaging gives you the ability also to tailor the treatment to the patient's anatomy. So when you're targeting a tumor, you can see the surrounding structures, the bowel, the skin, the nerves, other critical things that you want to try to avoid. And that also, of course, allows you to really precisely target the region of interest and spare those surrounding structures, again, minimizing the risk of side effects.
And how do you effectively communicate all this to patients, everything that's happening, those who might be skeptical or are simply used to the conventional approaches?
It's a good question. How do we communicate this? You're saying when we're, for example, for patient selection process, is that?
Mhm.
Yeah, let's start with patient selection. I think that one of the keys to new technologies, to any new technology, is to be careful with patient selection. Sometimes when something new comes along, it's the next great thing, and people start to search for as many different places to use it as possible. What we found over time is that it's really critical in terms of achieving excellent outcomes is to first be careful about which patient you're selecting for your treatment. For whatever we apply. If we're treating a patient with uterine fibroids, for example, it doesn't make sense to choose somebody with 10 fibroids and only treat 1 or 2, for example.
Mhm.
We've learned over time, for example, the MR appearance of the fibroids makes a difference. If they're darker on some of the MR images, they're more likely to respond to our treatment. In the prostate as well, patients that have multiple lesions or that have MR invisible disease may not be the best candidates. Other patients that have a very visible, very focal spot for targeting, that's more in our wheelhouse typically, for example. So I think patient selection is a key component of success. So during that interaction with the patient, first we're talking to them about the pros and cons of this treatment versus other treatments. We're in a stage right now where patients are often seeking us out. They have heard about the alternatives themselves. They may have gone, for example, to the urologist or radiation oncologist and heard about the options that they have there. They've heard about the risk profiles of those treatments, and they're looking for alternatives. Then we carefully go through our advantages and our disadvantages with them. Again, it's not the case that everybody is a great candidate for a treatment, and it's all about setting expectations going into the procedure. During the procedures, some of our procedures are done with patients awake. So when we do, for example, these tremor treatments, we are assessing patients. We ask them to draw spirals, to draw lines. We're testing neurologic function. We're looking for any side effects. And we're also communicating with them. Many of them come in anxious about the procedure that they're about to have. And it's not until they start to see how much improvement that they're having that now they're really very motivated. We'll have some patients that will come in and say, I'm okay with just a 50% improvement. That's okay. But then we treat them and all of a sudden they're 70, 80% better. We've exceeded their goals, but they want to keep pushing. Let's get 100% improvement now. And so, those things change. And that's part of a communication between the physicians and the patient to make sure, one, that we remind them of their original goals. So we talk about the pros and cons of continuing, et cetera. But the patient's very much a part of this, especially during these tremor treatments when they're awake. Other treatments are done with the patients asleep. And so a lot of the communication about expectation occurs ahead of time, going into the process to make sure that they're aware of the pros and cons of what we're doing and what their expectations can be afterwards with regard to recovery as well.
Now, do you have any success stories that stick out in your mind from patients being treated with these approaches?
Quite a few. It's been a while I've been doing these different things. Let's see, a few that jump to mind. I mentioned the bone treatments. I recall a farmer from Northern California who came in, and he had told us about how difficult it was to get here. He drove in his truck. Somebody else had to drive him. He was sitting on a pillow. He had a pelvic tumor that was causing him a lot of pain. So just the constant jostling in the car, the pressure of sitting was very painful for him despite medications. We treated him. He did very well. I remember I tried to call him for follow-up, and his wife told me that he was off in the mountains. He'd gone on a trip on horseback. So he'd gone from being somebody that couldn't sit comfortably on a pillow in a car to bouncing up and down on a horse up in the mountains.
Wow.
He'd been able to, his quality of life was really dramatically improved. We adapted this technology that was originally being used for fibroids and bone. We adapted it to soft tissue tumor treatments. And we did that in particular for a tumor type called desmoids. which are a very difficult tumor to treat. They're difficult for any treatment, including focused ultrasound. But the advantage of FUS compared to surgery, radiation, it's less invasive. There's less damage to surrounding structures, and we were able to adapt this for the treatment of patients with desmoid tumors. And again, the nice thing is that we can treat them and treat them again if we need to. It's not so invasive, and so there's a lower penalty to pay for retreatment. There was a young man who'd had a desmoid tumor behind his leg, behind his knee, and they had treated it surgically. It had come back. He'd ultimately had an above the knee amputation, and again the tumor had come back. And they were offering him, his orthopedic surgeons were offering him a hemipelvectomy, a really significant surgery. He was, I believe, around 12 or 13 years old at the time, really very young. Really, he'd already had kind of a devastating experience with the amputation, and now this was going to be even more significant. And working with our colleagues in orthopedic oncology, we treated this patient with focused ultrasound. We saw the tumor shrink. It came back again. We treated it again. A little bit of it survived. We treated it again. Ultimately, after 4 treatments, it was dead. And years later, his mom sent me a picture of him on his bicycle. He was mountain biking. He had a prosthesis, and so he was able to ride his bike. And it's just an incredible photo. Things like that are really inspiring. We had a music teacher who was in his 80s. He'd been playing the violins for 70 plus years, and played it and was now a teacher himself. We asked him to bring his violin in for us and treated his tremor, and then he played for us afterwards. That was amazing. Wow. To hear him play again. And I think that you can see on their faces the impact of what we've done. It's very gratifying.
That's incredible to hear. Switching gears, though, what are the biggest challenges in this area that you've experienced?
Well, I think there's been a challenge for adoption. These tools in some areas are increasingly available, for example, in the brain. In other areas, for uterine fibroids, for bone, it never really caught on. And some of it, I think, was because of the technology. That marriage to MRI has a technical advantage, but there's a cost, there's a technical expertise that's needed, and those things can slow adoption. Also, insurance companies have been slow to cover some of these treatments, and that can also, of course, both slow access for patients, and it may also make providers less likely to pursue offering the technology as well. What we've done as a way to try to encourage adoption is work very closely with each of our clinical colleagues. So when we're doing, for example, studies in uterine fibroids, we work closely between radiology and gynecology. When we work in prostate cancer, for example, I work closely with colleagues in urology. When we do these brain treatments, it's our team in radiology with the neurosurgical team. And what that does is bring all the relevant expertise to the room to bear for the benefit of the patient. It keeps everything kind of fresh and exciting and interesting for us as well. We learn a lot from each other. We have a lot of insight on the MR and ultrasound imaging and physics side of things. For example, the neurosurgeons know a lot about the neuroanatomy, of course, and how to tailor and adapt the targeting. And I think at the end of the day, these collaborative approaches really make a big difference for patient outcomes. And frankly, for the satisfaction that we as physicians get as well, being able to work closely with folks that are friends as well as colleagues here now.
Now, what do you believe is needed to grow the adoption and capabilities of these approaches?
Well, I think that's a challenging question, honestly. To grow adoption, I think there's a few things that are important. Some of it has to do with improvement in the technology. So right now, for example, this is something that's done in an MR suite in a hospital, for example, setting, or of course, it could also be done, and it is done in outpatient MR centers as well for some applications. If we could move this from that setting to an in-office setting, you could imagine that adoption would be much faster. and much easier for folks. If instead of requiring MR-guided focused ultrasound to treat a uterine fibroid, if there was an ultrasound-guided focused ultrasound system, that was something that the gynecologist could offer in her office, for example. If the urologist could treat urinary symptoms related to an enlarged prostate quickly with a device that was easily accessible in an office setting, for example, that would potentially drive adoption. I think that's one. Another technical improvement right now, we have some devices that are specific, so a brain-specific device or a prostate-specific device, but other applications were built around a more generic body system. And there are disadvantages to that. You know, a device that's designed for a woman to lie flat on the table to treat her uterine fibroids is challenging to adapt when you try to treat a tumor in the palm of the hand or the back of the ankle, for example. It takes a lot of time and effort and skill to kind of get everything lined up for those treatments to be done effectively and safely. So I think more application-specific tools make a lot of sense as well. I think another thing that's critical for all of this is to continue to develop high-level data. It's going to drive adoption. It's going to make an impression on both the referring physicians as well as the treating physicians. And I think also it will have an impact on insurance coverage as well. I'll give you an example. You know, the quality of data that led to the approvals for treating essential tremor, for example. There was a study done initially on a pilot study, then a larger multi-center study, both of those published in the New England Journal. There have been follow-on studies following these patients out to now 5 years, showing the durability of the effects. These had a big impact on the neurosurgeons, primarily, that were seeing these patients and were considering treatment alternatives for those patients. And it led to the neurosurgeons being excited and interested in offering this technology. Their neurosurgical societies, neuroradiological societies as well, all supported the use of this technology for these patients. And that led to more rapid adoption. And then when it came time for insurance approval as well, these experts in neurosurgery, radiology, et cetera, were all able to advocate for the technology on behalf of the patients. And that led ultimately to insurance approval, both on, on a Medicare national level, but on individual local providers as well as private insurances over time.
Now, to the points that you just made, any future research that you or colleagues are planning?
Well, so a study that was recently completed, I think, following on the question you mentioned about that I was describing about data quality. Mm-hmm. One of the challenges has been in terms of proving the value of focused ultrasound has been when we set up clinical trials where patients get randomized to focused ultrasound versus something else. Patients often, when they get randomized to that other thing, they don't want to participate anymore. And the reason they're interested in focused ultrasound was they wanted to avoid that other thing, whatever it was, surgery, let's say. People have tried repeatedly to set up these clinical trials to rigorously compare these two arms. I'm really delighted. We recently, as part of a multi-center study, we have done a clinical trial, participated in a clinical trial that compared focused ultrasound, specifically transurethral ultrasound ablation, MR-guided, TULSA it's called, for the treatment of prostate cancer versus standard of care prostatectomy. So frankly, the ability to recruit patients to that study and have them accept their allocation to the different arms. So that study is now just going to be a gift that keeps on giving. We're going to have a decade now to follow these patients. We already see, of course, that their time in the hospital is less after the ultrasound treatment than it is after surgery. Their recovery of function and so forth seems to be faster. But now we can follow these patients over many years, look at recurrence rates, look at long-term side effects from these different treatments, and really have a rigorous comparison between these two approaches. So I'm excited about that. As far as newer applications, I think in the body, pancreatic cancer, I'm really motivated by these diseases that don't have other great options for treatment, or where the options are either limited or the outcomes aren't great or the side effect profiles are significant. Pancreatic cancer, as you may know, is a devastating disease, and it manifests late. The surgical option is really only available for patients that happen to be found in early stage disease. So what do we do with these patients that show up typically with later stage disease? So we have a couple of clinical trials that we've opened here using different modalities, different mechanisms of action of focused ultrasound. One uses the ultrasound as a way, combined with microbubbles, to enhance delivery of chemotherapy. So they're getting that chemo anyway, but can we drive more of it to the cancer? Some exciting early results there. And then another uses a combination of cavitation plus thermal ablation as a way to enhance treatment and destruction of the pancreatic cancer. That's a second study that we've opened up recently. I'm excited about that as well. There are studies going on globally looking at the use of focused ultrasound, for example, with another mechanism called histotripsy, which is cavitation-based, also targeting, for example, pancreatic cancer, but also soft tissue tumors, a number of other exciting applications coming down the pike, I think, and we'll hopefully see the fruits of that soon.
These are results that we'll certainly be on the lookout for. Doctor, thank you for joining us today. Any other thoughts before we end this recording?
I think, one of the things that excited me about this technology as a kid growing up watching Star Trek, you think about how they treat illness on that show. It seems miraculous. Kind of wave something at the patient and diagnose them and then treat them. And, frankly, that's the vision that we have. MR is being utilized increasingly as a way to diagnose disease. You can use MR, for example, to visualize a spot in the prostate that is abnormal. Under MR, you can biopsy that spot. And now with MR guidance, you can treat that tumor as well. I think there's a lot of elegance to this, the ability to target specifically the area that's abnormal and rid the body of that disease while minimizing any side effects. To me, it's really kind of the future is here in some ways with this technology.
That's all for today's show. Be sure to check out the ultrasound section on antmini.com for the latest news in research, practice, and policy. And don't forget about our other podcasting series on the Ant Mini Podcast Network. Stay tuned for the next episode of the Ultrasound MinnieCast, and we thank you for your continued support. Until next time.